Good morning, good afternoon, good evening, wherever you are. It's a pleasure to have you here at the WHO RSV Roadshow web series. My name is Lewis Bond, and I'm the chairman of the RSVNet Foundation. We have prepared, together with PATH and WHO, the RSV Roadshow series, a communication toolkit with several web events that you can see at the right side of the screen. We specifically try to target the audience of policymakers, decision leaders, and people who are interested in immunization and prenatal care communities in the low and middle income country settings. We aim to increase awareness of RSV, prevention options, and implementation strategies for informed decision making. We have modular PowerPoint slides with speaker notes available for in-depth exploration. We advise you to look them up. You can see the website at the bottom of this screen and use them at your liberty. So this is the second web event on RSV clinical disease and burden in infants. I would like to remind you that we invite you to use the Q&A button for questions during and after the presentation. At the end, we will use them for an interaction with our esteemed colleagues. First of all, we have my good friend Jan Englund, who is a professor of pediatrics at the University of Washington in Seattle and an affiliate investigator at Fred Hutch Cancer Center. Dr. Englund is actively studying respiratory viral vaccines in diverse populations, in particular in low and middle income countries. She will speak first. Then we have been able to attract Leo, or Yu Li, who is a professor of epidemiology at the Nanjing Medical University in China, and he's an honorary fellow at the University of Edinburgh, where he is leading the infectious disease epidemiology and modeling group in Nanjing, and his group has done groundbreaking work in the field of respiratory epidemiology. And then finally, we have asked Professor Ziad Dangor to reflect on what we have heard from Jan and Leo, and he is working at the Vaccines and Infectious Diseases Analytics Research Unit at the University of Witwatersrand in South Africa. He is the clinical research director at the world-renowned Vaccines and Infectious Disease Analytics Research Unit, and he also works as a pediatric pulmonologist at the Department of Pediatrics at the Chris Baragwanath Academic Hospital. So, we have our second Roadshow web event today, Clinical Disease and Burden in Infants. So why do we focus on RSV and why now? I've seen a lot of the people who are participating who already know this, but RSV is the world's top cause of severe respiratory infection and hospitalization in babies. And there are new immunization tools emerging, registered, that are able to change that. And we need to change that, because at the bottom of this slide, you see the call to action. Now is the time to raise awareness and support global, regional, and country decision-making around RSV prevention, policy, and implementation preparedness. So without further delay, I would like to give the floor to Jan to tell us about the clinical presentation of RSV in young children. Jen, the floor is yours.
Thank you. And it's just a pleasure to be here to talk about RSV, one of my favorite subjects. I'm going to cover symptoms, disease severity, diagnosis, and treatment. And remember, there's a Q&A button at the top. So if you have questions, ask your questions and we'll answer them later on in the presentation. So the agenda of my talk is to cover RSV clinical disease and inform clinicians as well as public health persons. What is RSV? What does it look like? Particularly, what does it look like in young children? I'm not going to cover older adult RSV. And how is RSV currently managed? What is the diagnosis, treatment, and prevention of RSV? So, what is RSV? It is a virus. It is a respiratory virus that almost all children get before 2 years of age, and certainly by 3 years of age, it's 99.9%. Everyone gets it at some point in their lives, and you can get it again and again. The presentation of this virus is often mild. It starts often with a cold, a runny nose, but it can be severe or even deadly, especially for the youngest infants or vulnerable infants. It is transmitted via sneezing, coughing, touching contaminated surfaces, and then touching one's own eyes, nose, or nasal or mucosa. So if the baby is not in the bed and you touch the bed, you can still get RSV. The immunity is good, but infection-induced immunity is not fully protective. So there are lifelong infections, and you and everyone can get RSV repeatedly. The pediatric populations at risk of severe disease really include any child, especially in the first 6 months of life. Most with the severe disease are actually full-term, previously healthy infants. They have no underlying health conditions. That represents nearly 80% of all these children who get hospitalized and some of those who go on to die. But additional factors that definitely increase the risk include prematurity and comorbidities, especially underlying heart and lung disease. And finally, living in socioeconomically disadvantaged areas is also a risk factor. So, RSV importantly affects the lungs and the breathing passages. The symptoms often occur, or the main symptoms occur 3 to 5 days after infection and can last up to 10 days. Initially presenting as only a runny nose like a cold, it then goes on and infects the respiratory epithelial cells of the respiratory system, and it triggers a host inflammatory response. The symptoms start in the upper respiratory tract. We call it upper disease. They're typically mild, and then it can go on to affect the lower respiratory tract, the area shown in pink, which includes the trachea and the lungs. So symptoms of upper respiratory disease include runny nose, nasal congestion, and earache, and otitis media. The lower respiratory tract includes coughing, wheezing, and breathing fast. And in general, all these children, whether it's upper or lower, have a low-grade fever. Often the fever is early and can go away, but the fever can be at any time. Apnea or stopping breathing is a common presentation for the youngest infants. Infants don't feed well, particularly breastfeeding, and the young infants with a stuffy nose and hard breathing makes them not eat well, leading potentially to dehydration. So I'm now going to talk about severe RSV disease. So RSV disease is much more likely to progress to the lower respiratory tract, that is the lungs and below the neck, in infants due to their small airways. And these infants, particularly under 6 months of age, and you can imagine the premature infants who are even smaller, therefore are at highest risks. The infant airways are already small. They're easily obstructed by mucus and inflammatory products, which you can see on the bronchial airway on the right picture here. This can lead to severe complications. You can see here the mucus and the inflammation making the airway diameter very small, which leads clinically to the process we know as wheezing. So we know in infants with lower respiratory tract infections, 1 in 5 or up to 20% can experience apnea, particularly the youngest infants under 4 to 6 months of age. And up to 85% have fast breathing. Now, common complications of severe RSV disease include lung type issues. The most common complication is bronchiolitis. Bronchiolitis is inflammation of the bronchioles, which are the small airways in the lung. It causes wheezing and difficulty breathing, and it appears clinically as these chest wall indrawing, where you can actually see the muscles between the ribs work, which we call retractions. It causes fast breathing. The nose flares out. We call it nasal flaring. And often you can see a change in the lip color on even the fingernails where it changes to a blue or cyanotic color. You can see in the picture here, this is due, we think, to the mucus and inflammation within the bronchioles. And finally, in the more severe disease, it leads to pneumonia, which leads to inflammation of the lung. Often there's fluid filling the terminal air sacs or the alveoli, making air exchange and oxygen exchange difficult. And on chest x-ray, which you don't need to necessarily get, but if you do get a chest x-ray, you can see scattered interstitial infiltrates on the chest x-ray. Generally, it's bilateral. Generally, it's throughout the lung. But this is something that really does concern those of us taking care of young, sick children who are breathing fast. So what are the signs that young children need medical attention? Not every child with RSV needs to be seeking medical attention, but there are multiple signs that could be useful because medical care can reduce the morbidity and mortality of RSV. Hospitalization is much more important and likely to consider when RSV is in the lower respiratory tract, that is, when it's in the lungs. The lower respiratory symptoms mean that medical attention is required. And some of these complications would include, and you can see on the left here, respiratory-related complications or signs, difficulty breathing. And we use in our clinic a rapid respiratory rate, and we use over 60 breaths per minute. This is an easy sign for clinicians and parents and nurses and everyone to know that's 1 breath a second. If the baby is breathing that fast, that's trouble. The chest wall, if the chest wall is sucking inward when inhaling with these retractions, that is also a concerning sign. And when you can hear the wheezing or grunting without a stethoscope, when it's when it's audible, when you can hear it with your own ear without a stethoscope, that's also concerning. Now, in general, there are other signs that an infant will need medical attention. And probably the most common issue is the infant or child is unable to drink or nurse due to breathing too fast and due to having nasal congestion. This can result in dehydration. And if the infant is weak or appears too tired, it can lead to actually increased work of breathing on top of the already RSV-related increased work of breathing. And certainly if infants have low oxygen levels based on gray or blue skin or lips or fingernails due to low oxygen levels, that would mean that medical attention should be sought. Now, what I would like to say is that an important part of evaluating children, of course, is looking at them, but physical examination is really the most important. Low oxygen saturation occurs only in a minority of infants and young infants. It is not a reliable diagnosis for lower respiratory tract infection. Physical examination, looking at the baby and talking with the parents are really important to see how truly ill the child is. RSV can be deadly. Premature birth, underlying health issues such as heart and lung disease can increase the risk for severe RSV disease. But importantly, most deaths globally and in low and middle income countries, economies, are in infants that are born full-term and before 3 months of age. So even though we are talking about these preterm babies and these babies with congenital heart disease and underlying lung disease, that really is a minority of the infant deaths. The majority are in healthy full-term babies who just have the unfortunate luck of getting RSV before 3 months of age. So how do we diagnose RSV? RSV shares symptoms with many other viruses like influenza, rhinovirus, and even COVID-19. So it is very difficult, and for me, it is impossible to make the diagnosis just by clinical signs and symptoms. It's interesting that some people say they can. I don't think you can when you really, really get down to it. Despite this problem in many settings, bronchiolitis and what we call epidemic bronchiolitis in young infants is a strong marker for RSV. When your clinic is full of these babies presenting with difficulty breathing, with retractions and wheezing, often that is a sign that RSV is in the community and that your patient may have RSV. But to definitively diagnose it, you need testing. And these tests can be done by a rapid antigen test or a PCR test. And although the antigen tests are less sensitive than RT-PCR, they can still be helpful. In my setting, often the beginning of the season is helpful because that's when you're trying to figure out, is RSV coming into your community? Perhaps by a few weeks into the epidemic, we don't need to do quite so much diagnostic work at all. But when you do have a diagnosis, it helps enable providers to determine the treatment, the need for hospitalization, potentially decrease the unnecessary use of antibiotics, to raise awareness of disease among the community and healthcare workers, and even families. It can identify outbreaks in the community and refine the seasonality of the virus so that families, healthcare workers, clinics, hospitals know what time of year you really should be concerned about RSV. Now, the current treatment for young infants is truly supportive care. Supportive care is critical to manage infection. Supportive care can save lives, and these cares are relatively simple and straightforward. So, importantly, respiratory support and monitoring is important. That includes potentially giving the child oxygen. In relatively rare cases, it could include mechanical ventilation, but oxygen alone really will help comfort the infant and help. The second most important thing, in my opinion, is hydration. One can assess the skin turgor, how tight and elastic the skin is, assess the urine output. Young babies should be peeing, and they should be having urine output every 4 to 6 hours. Therefore, consider IV fluids if there's marked respiratory distress. Sometimes these infants are breathing so fast and so tired that they're unable to actually take liquids orally. So that is important. Fever. We really don't want babies to have fever because if they have a high temperature, that will increase their respiratory effort and it will increase dehydration. So acetaminophen can help decrease respiratory effort and maintain hydration. Steroids, this is a do not give medicine. We don't need steroids for infants with RSV. It's been shown and proven we don't need to do it. Antibiotics sometimes are indicated, and it's difficult depending on your setting to know whether or not to give antibiotics. But what we do know is inappropriate antibiotic use does pose a resistance threat for resistance to all these antibiotics. So what is the main take home for the current treatment for young infants? Keep the babies warm, clean, comfortable, closely observed, hydrated, oxygen. That will prevent many, many complications of RSV. So with this, I'd like to give you the key takeaways for understanding RSV disease. RSV is the top cause of severe respiratory infections and hospitalizations in young infants, and interventions are here, but not yet widely available. It's also not really well known what can be done in all settings, despite the huge burden of illness. It's crucial that clinicians and families and health workers understand that RSV is typically mild, but when it is severe, it can lead to very serious complications, including death, and particularly in young infants. Lower respiratory symptoms require medical attention and potential hospitalization, and RSV can be hard to distinguish from other respiratory illnesses or pneumonia. And finally, supportive care is critical to managing RSV disease, particularly in the absence of diagnostic tools or preventive products. And with that, I would like to move forward to our next speaker, and he will talk about global and regional RSV disease burden. Thank you.
Thank you, Jenny. It's my pleasure to give you the presentation of global and regional RSV disease burden, which is a huge and recognized public health problem in infants and young children. So before I get started, I wanted to remind you to use the Q&A function to ask questions. And if you find someone's question helpful or you would like to hear the answer, please also feel free to vote for that question by using the sum up function there. So now that we've heard about what RSV looks like clinically, now let's talk about RSV disease burden. And specifically, I will take you through what we know in terms of the global RSV mortality and morbidity, as well as the RSV disease burden in children by WHO region. So RSV is a global disease that sickens children worldwide, and almost every child is infected with RSV by their second birthday. And recently, our group showed that our group estimated the global RSV disease burden, which was published in the Lancet, and these estimates found that globally, among children less than 5 years of age, RSV was responsible for 33 million episodes of acute lower respiratory tract infections, 3.6 million hospitalizations, and over 100,000 RSV deaths. And overall, RSV accounts for 2% of the global mortality burden in children under 5 years of age, and 3.6% among children under 6 months of age. So if we look at children under 6 months of age, this is the age group that accounts for 20%, which is 1/5 of RSV acute lower respiratory infection episodes, but almost half of RSV deaths in children under 5 years of age. And this is also the age group that the new RSV immunization products will protect. So to put things in perspective, RSV is responsible for 1 in every 28 deaths that occur before the 6 months of age. It's a really tragedy that still happen until we do something about it. Although we show that RSV infects children worldwide, it's not equitable in its consequences. Actually, what we found from our estimates was that over 98% of RSV deaths occur in low and middle income economies. And as you can see on the graphic on the left-hand side, you can see the rate of RSV mortality among RSV cases is very low in high-income countries. But you look at the middle panel, which shows a higher rate of mortality because many children in low-income economies never make it to a hospital. And in these settings, 4 times as many children die from RSV in the community as in the hospital. And this is because children in low-income economies, they are less likely to have access to adequate medical care, and so are far more likely to die from RSV at home. And this point is further illustrated by a recent study of community-based mortality study in several low and middle income countries. And the countries in the study shown in green here on the map are, the study investigators, they swabbed the nasopharyngeal swabs of babies who had died in the community within the 48 hours of death. And based on this study, we show that the percentage positive swab for RSV ranged from 3.7% in Pakistan here to 27% in the peri-urban slums of Argentina. And of note, all of these detected RSV may not have necessarily been the causal chain of death. In another study called the CHAMPS, they undertook minimally invasive tissue sampling in children who died in several low and middle income countries. And these countries are shown in the dark pink on the map here. And we can show here, these results are generally consistent with the community mortality study here. And specifically in the CHAMPS, they detected RSV in 9% of all deaths among infants less than 6 months of age, and a panel of experts deemed RSV to be in the causal chain of 5% of these deaths. So if the results as shown here in both studies are consistent in other low and middle income countries, then that really suggests that the burden of RSV mortality in children under 6 months of age could be even double the previous estimates. And RSV also plays an important role in causing severe and very severe pneumonia in low and middle income countries. So in this PERCH study, which was conducted among 7 countries in Africa and Asia, the study investigators found that RSV was the most common etiology for both severe and very severe pneumonia by orders of magnitude in 7 countries. So you can see RSV has, the really big circles here and really, substantially larger than the other pathogens. And overall, it caused 31% of all severe and very severe pneumonia in these countries. So let's get into what some of the regional data tell us. So now what we can see are the results from another project on RSV disease burden globally, but this time by WHO region, which focuses on the pre-pandemic, pre-COVID-19 pandemic years during 2010 to 2019, and is only focusing on lower and middle income countries. And this is as yet an unpublished systematic review and a meta-analysis of countries and looking at the percentage of children hospitalized with acute respiratory infections who are tested positive for RSV. And this study includes 73 studies in 32 countries, as you can show here, with all of the 6 WHO regions well represented in this study. So overall, this graph shows what is the proportion or percentage of RSV positive among all acute respiratory infection hospital admissions among children under 5 years of age. So overall, the percentage ranged from 1 in 4 to 1 in 3 across the 6 WHO regions. And if you look at specifically the younger age group, which is the under 6 months of age, the proportion is even higher, which is 1 in 3 to 1 in 2. And what's again critical here is that the new RSV immunization products, both the maternal vaccine and the long-acting monoclonal antibodies, they can protect in this age range, and which underscores the urgency in advancing the availability of these products in low and middle income economies. And now let's return to a reanalysis of our published 2019 global RSV disease burden analysis that I just shown you a few slides before. But this time we have broken down the estimates by WHO region. And these data were available from 107 studies from all the 6 WHO regions, as shown by the yellow dots on the map. All the regions have a high burden of RSV-associated acute lower respiratory infections among infants under 1 year in all of the 6 WHO regions. And specifically, the greatest number of cases came from Africa, over 4 million per year, and Southeast Asia, over 2 million per year. And this graph shows the number of RSV-associated LRI hospitalizations among infants by WHO region. And the largest number of hospitalizations are in the Southeast Asia and Eastern Mediterranean region, with over 500,000 RSV hospitalizations per year in each region. And compared to the previous slide, you will notice that the number of hospitalizations in this slide in Africa is lower despite the greater number of community-level RSV LRI episodes. And this graph shows the in-hospital case fatality ratio. And you can see some variations here by region, with the highest in-hospital case fatality in Africa at about 1.5%. And admittedly, this is a relatively low case fatality ratio compared to bacterial pneumonia, for example. But this really shows that if a child with RSV makes it to the hospital for treatment, then they will have a very high chance of surviving. But remember that in low-income countries, there are 4 times as many RSV deaths occur in the community as in the hospital. And it is for this reason that despite the lower rate of RSV hospitalization in Africa, that the number of RSV deaths is by far the highest in Africa, accounting for over half of the global burden of RSV mortality. And to go beyond, RSV impacts go beyond just illness and death. It also has a huge burden on the health systems and households. While the overall cost of treating RSV are higher in high-income countries, the actual burden on the health system and households themselves might be greater in low and middle-income countries. For example, the average cost for a single hospital inpatient visit for RSV has been estimated at 32% of a household's monthly income in Malawi. And in Bangladesh, the median out-of-pocket cost of RSV hospitalization is around 24% of monthly household income. For poorer families, this percentage could even rise to 32%. And in terms of costs to health systems, the median annual direct cost of hospitalization in Bangladesh is around $10 million. And the PERS study found across 4 African countries, a range of 5 to 10% of all hospital admissions among children under 5 years of age were due to RSV. And overall, if we think about the widespread RSV prevention programs, it could go a long way toward freeing up valuable resources for households and health symptoms and health systems. And lastly, I wanted to briefly mention RSV seasonality, which is the topic that our group has been working for many years. And in developing RSV prevention strategies, RSV seasonality will be an important consideration. So RSV seasonality could vary by different parts of the world, but generally seasonal RSV activity is observed in many areas. In temperate regions, usually we could see clear RSV seasonality, which is usually during autumn and winter. In subtemperate or subtropical areas, there could also be RSV seasonal peaks, but the level of the peak may be a bit lower, and there could be also year-round circulation in some of the subtropical settings, like Hong Kong. And also, equatorial areas have year-round circulation. For example, in Singapore, there could be year-round RSV activity, and there were no, distinct RSV seasonalities usually in Singapore. And the timing of RSV circulation could also vary year from year, even adding complexity to prevention efforts. And in some of the geographical large countries or some of the countries that have multiple, climate zones, the RSV seasonality could also vary within the country. So far, I've shown you the results of, RSV disease burden. And now I'd like to use this slide to show you some of the preliminary results of RSV surveillance studies, which have taken place over the last couple of decades. And again, all of the 6 WHO regions are well represented. And here, this slide only shows where the RSV surveillance is taking place today, and only shows RSV studies in which WHO is involved. And as you can see, that there are many countries continuing to do RSV surveillance in children with very good global representation. And the current RSV surveillance in which WHO is playing a key role include the Global Influenza Surveillance and Response System, the GSUS system, CAHO's Severe Acute Respiratory Infection Network, also known as SARI-NET, and also the European SARI Vaccine Effectiveness Network, the EuroSafe. Lastly, in conclusion, RSV burden in children is great in all WHO regions. And we see that about 1 in 3 to 1 in 2 of all hospital admissions for acute lower respiratory infections are likely due to RSV. And over 100,000 deaths occur from RSV each year, and half of which occur in the first 6 months of life, with a disproportionate burden in low and middle income countries, and likely due to the fact that children there are not being able to reach hospital care in time. And RSV also causes a huge burden on household incomes and on the health systems. And RSV seasonality should be considered in introducing RSV prevention. And lastly, to help understand the local RSV disease burden, decision makers in countries can either look into the existing data from their own region or try to establish RSV surveillance in their own country. And with that, I'd like to end my presentation and hand it over to our next speaker, Ziad. Thank you.
Thanks very much, you, and good day, everyone. So for the last part of this talk, I'm just going to share some of my reflections as a pediatric pulmonologist from South Africa, and some of the nuances which you've heard of, but putting it into a contextual point of view. So I think it goes without saying, and I think the important point that both speakers have highlighted is that RSV is a big problem. But I just want to come back to this point, is the number of children being hospitalized in LMICs from LRTI, or lower respiratory tract infections, is now the commonest reason that they be hospitalized. And we heard that RSV is the commonest reason for LRTI. So I think the first very important reflection that I want to make is that this is a common problem. The second important reflection is that we know that the burden in LMICs seems to be leaning towards a younger age group. And this is the age group, as Janet was saying, that the mortality risk is higher. And this is also the age group where we see a lot of the deaths occurring out of the hospital and in the community. And further to point that the age of presentation may also be younger in these children outside the hospital setting. And one must recognize that neonates can present with apnea as their presentation for RSV LRTI. Another important point that's been highlighted by you is that we see an increase in the community deaths occurring in the RSV season. And I think that's reflective of the children who are not reaching the healthcare facility that are dying likely from an RSV-associated LRTI. Another point that I want to reflect on is that the RSV LRTI in infancy predisposes children to sequelae. The first sequelae is the risk of recurrent lower respiratory tract infections that happen in children that do have an initial RSV LRTI. But more importantly, it may lead to long-term respiratory sequelae, including recurrent wheezing, asthma, and impaired lung function. And this sequelae in early childhood may persist into adulthood, resulting in long-term need for healthcare. Another important reflection that I'm making here in this slide is that, and I've seen a question in the chats as well from Martina, is that we are concerned, or should we be concerned about bacterial co-infection? So these are three studies that I'm showing here. The first study on the left-hand side is from the US that shows that the proportion of children with viral bacterial co-detection, and I'm using the word co-detection because these were NPOP swabs that were done. The prevalence of co-detection is lower in the US as compared to two studies done in South Africa. The first study was the PERT study, so it included South Africa as well as other African and Asian countries. And the study on the right-hand side was the Drakensberg study that was in Cape Town, South Africa. And what you're seeing, as illustrated by the red outline, is the proportion of children that having viral and bacterial co-detection is higher in countries like South Africa and other countries in Africa and Asia as part of the PERT study compared to a high-income country like the US. So then to partly answer the question that's been put in the Q&A, and then really encouraging listeners to put your questions in the Q&A around the presentations that you've had today. But to answer the specific question in the Q&A, who do you then consider for antibiotics if there is a risk of bacterial co-infection? The important point to highlight, and this is findings from the CHEM study as well, is that children who demised from pneumonia, a large proportion of them had multiple pathogens identified on the lung histopathology and lung microbiology. And what this is really telling us is that the severe cases or the severe disease presentations are more likely to be the ones that have bacterial co-infection, and possibly those that also have underlying chronic medical conditions or comorbidities. So the final side of reflections is really around settings with limited resources. So the first point I'd like to make is that there is usually no laboratory testing or surveillance undertaken in most parts of Africa and Asia. As you has pointed out, there is these sentinel surveillance sites that do surveillance, but from a clinical point of view, this is largely non-existent. So having seasonal patterns to RSV or seasonality to RSV does provide some benefit to the clinicians, as they would recognize that a lot of the admissions during that period of time may be from an RSV-associated illness. Or they may need to look at sentinel surveillance sites close by to them to determine whether there is a peak or increase in the number of cases of RSV. The second point I want to make, and this is a very important and my final take-home point, is that increased hospitalization rates during the RSV epidemics or seasons really places a huge burden on the healthcare setting. So as you told you that the number of people, the income used by the household in these countries is detrimental to that household income. Up to 30% of someone's household income per month can be used to pay for hospitalization of RSV. But here what I'm talking about is I'm really talking about the burden on the healthcare sector. So the first point is that children with RSV would compete for bed space, including the access to intensive care facilities. Not only are they competing with other children who require hospitalization for RSV, they compete with children with non-RSV related illness. Often we find that bed capacity is over 100% during these RSV seasons, and most of these settings are unable to turn children away who are ill because that may be the only healthcare facility that they can access. Another important consideration is staff burnout and reduced quality of care. And colleagues, this is an important realization, is when the healthcare sector is faced with this large number or influx of hospitalization from RSV, staff do feel the burnout that's associated with that. And the care to all other children is then reduced because you are spreading the care over a more number of children in the hospital. And then the impact on the management of other illnesses. I think the important point to highlight there is that children with elective procedures or require elective procedures, children with non-communicable diseases are often compromised because of the large burden of RSV hospitalization. And what we see is that they may be competing for ward or post-ICU space from their procedures. And there's obviously then the increased risk of severe hospital-acquired RSV disease that may occur in these high-risk patients. So certainly the burden during the RSV season is something that does cripple the healthcare sector, particularly in LMIC or low-resource settings. And that's really the last of my reflective slides. And I'll hand over now back to Louis for the Q&A.
Thank you so much, all three of you. It was a pleasure to hear Jen's explanation on the clinical picture of RSV bronchiolitis in children and Leo's understanding of the burden of RSV globally and your personal reflection how RSV affects a lower middle income country setting. So the first question by Patricia was how she can access the presentations, and the PowerPoint is accessible through the PATH website, and the web event can be reviewed by the ResWeNet website. So Jen, the first question for you is about RSV in the very young babies. Maybe you can tell us a little bit about RSV in neonates, that seems to be following a specific, very difficult to recognize course of symptomatic events. And can you speculate on the role of maternal antibodies? Jen.
Thank you. Great question, and one that I'm very interested in. I and many of us are very interested in. First of all, disease in neonates, RSV disease in neonates, is really complicated, as Louis pointed out. They generally do have a little bit of a rhinorrhea or a runny nose, but after that, the symptoms are very non-distinct and not easy to identify. The infants can present just with stopping to breathe. That can be a common presentation, which is a very serious and deadly complication. Often neonates, especially in the first few weeks of life, they're too weak to cough much. They don't have a great respiratory reserve. So the disease is really difficult. And of course, those of us pediatricians have to do a workup to rule out sepsis, bacterial infection. Those are kids that we do put on antibiotics because we don't know what's going on at first, especially if you don't have diagnostic tests available. Those babies do need antibiotics until you figure out what's going on. And they absolutely need close support. If you don't have cardiac monitors, you need someone by their bedside all the time to just stimulate the babies, because if you can just stimulate them, touch them, you can help them breathe because it works. So simple methods can work for neonates. The second question really is about maternal antibody, which is a really, really good question that has been studied now for 50 years. A long time ago, people didn't know if maternal antibody was present or if it helped. And I think there's incredibly good evidence now that maternal antibody, that is the mother's antibody that gets passed on to the fetus and is present at the time of birth, is really good for babies. And it prevents RSV, or at least it delays the onset of RSV in young babies, even those, we're finding out, even those who are preterm, maternal antibody does get across to some extent. So knowing that maternal antibody is good, the question would be, is more maternal antibody better? And that really is why we've tried studies of maternal RSV vaccine that have been conducted worldwide in LMIC and the US and Europe, and that has been shown to work. So giving infants more antibody, whether through their mother prior to birth or at the time of birth, which is given as a shot of a monoclonal antibody, those methods give more antibody to the baby, and they can delay or ameliorate, make the disease much less. So maternal antibody is good. You'd like more, and there's ways of giving more these days with vaccines, which WHO has recently discussed at recent meetings. So thank you.
Thank you very much. That was very clear. And I want to engage Ziad and Leo in the discussion on antibiotics or the role of bacterial infection. Would you, Leo, and then Ziad, take a moment to speculate on the role of RSV in bacterial infection and the use of antibiotics? Because this is a topic that we are not yet clear on. So from the epi side and from the clinical local perspective side, please give me your thoughts, Leo.
Thank you, Louis. So this is a really good question. From the IP side, I think looking at existing evidence, compared, if we look at the prevalence of bacterial co-infection with RSV, it's not very common. I can't really I don't have a number with me, because also it could vary from setting by setting. But overall, my impression is that the prevalence of co-infection with bacteria with RSV is relatively low. So that's my observation.
Thank you. So even though RSV can cause bacterial infection, the incidence may be limited, but there may be an unexpected or unaccounted for benefit if we start to decrease the RSV burden. Ziad, what do you think?
Yeah, so thanks, Louis. So I mean, I'm going to answer this from an FPN as well as a clinical point of view. So let me start with the clinical point of view. There is probably the most anxiety for a clinician to decide whether they should start antibiotics, for example, in a child with bronchiolitis. I know junior colleagues keep asking, should we give antibiotics to children with bronchiolitis, for example? And we know that most of children with bronchiolitis have RSV. And this is something that we've really been struggling with, particularly in our setting, where we recognize this as an increased prevalence of bacterial co-detection. And I want to be clear here. The one thing is blood culture sensitivity is poor. So we can't use blood culture as a measure to determine whether children have bacterial co-infection. So that's the first thing. The second thing is we can't go stick needles in all children's lungs to determine whether there are other pathogens. So that puts us in a real predicament. So then we turn to these pneumonia etiology studies that have been done where sampling of the upper respiratory tract has been used as a guide to determine what's happening in the lower respiratory tract. But as my colleagues have already mentioned, it's not common. It's not common for children who have RSV bronchiolitis to have bacterial infection, except for a few considerations. And these are the points for me. The point is there is a select group that one needs to consider when one needs to initiate antibiotics. And the first is that if a child has severe disease, you don't have time to play with. That's the unfortunate part. You have to act if a child has severe disease. If this child is on the bounds of an intensive care unit or requiring ventilation, most clinicians would agree that we need to give antibiotics because the child has severe disease. The second point is that are children with comorbidities more likely to have bacterial co-infection? For example, are children who have HIV, for example, children who have malnutrition, as someone has put in the chats, more likely to have an increased risk of bacterial co-infection. And certainly what the CHEM study has shown us is that the underlying cause of death in these children could be from causes like malnutrition and HIV. And when you're identifying RSV in the lung, you're not identifying it as a single pathogen. You're normally identifying it with a host of other pathogens, particularly bacterial infections from pneumococcus, Klebsiella. So I think antibiotics may be warranted in severe infection and children with comorbidities. Thank you.
Thank you very much. So Jen, there is a question about the use of diagnostics in the coming time when we're going to introduce RSV vaccines from Katia Kilonis. And so there is like a challenge because diagnostics may come at a certain price, but unless you test, you don't actually measure RSV. You explained that actually you touched upon the topic. Can you explain it again, how you would ideally would like to see RSV diagnostic being introduced in the lower middle income countries?
Well, first of all, I would like to say that diagnostic approaches to RSV are becoming more widely available and becoming less expensive. I think due to the COVID pandemic, there's a lot more availabilities, particularly these antigen tests, which aren't exactly perfect, but they're really much better than nothing. And that's number one. And number two, centralized hospitals who might not test everyone, but might be able to test at least the kids in the ICU can indeed make the findings known. And many places now have websites where clinicians can go and see that there's actually RSV in the community. In our hospital, we do that too. We publicize it. And our pediatricians, they want to know that there's RSV in the community. Sometimes it makes the newspapers or the television or certainly the blogs. So knowing that there's RSV in the community, which can be led by whether it's the government health surveillance, but a local hospital or a local pediatrician who helps run the ICU is very helpful, because I don't believe you need to test every child who shows up in the clinic with outpatient bronchiolitis. Outpatient bronchiolitis, while concerning, and if the child's breathing 40 times a minute and is 6 months old and feeding well, those babies may not need to go in the hospital, may not need a test, but the parents or family needs to be made aware if things get worse, the child needs to come back. So I think we have the outpatient setting where kids are doing reasonably well, and we don't necessarily need to admit them. We don't necessarily need to test them. And then we have these really sick children, which we just heard about. And those sick children having a way to test at least some of them in the hospital is so very helpful to know what's going on. And as you said, as we get more RSV preventative measures, I do think testing is going to be more important. I know there's tests available now in China that can actually look for flu, RSV, and COVID all at one time for under, for the cost of a couple euros. I think if we can get more availability of those kind of rapid, reliable tests that can be available at least at sentinel hospitals, it will be very helpful for us clinicians. Thank you.
Thank you, Jen. And before we go to the last question, which is about maternal antibodies, also for you, Jen, I saw that there are a few questions about the use of immunization strategies in low and middle income countries. And we are going to have web events on preventive interventions. And at the moment, there's very little use of those interventions. And I don't think anybody has a full insight in what is happening in those countries. So we postpone those questions for later. Jen, the last question for you. What is the role of maternal antibodies in breast milk, maybe to sustain the protection of maternal antibodies and maternal vaccination? Any thoughts?
Oh, I have many thoughts. and some of your people and our people have worked together. So there's number one. The social benefits of breastfeeding are incredible. The fact if the mother is holding on to the baby and not handing the baby around to be bottle fed by other people means that the number of contacts are much less. So breastfeeding is good for nutrition. Breastfeeding is good for social distancing of the baby from other people. We know that RSV gets brought into the family by other children, older siblings. So breastfeeding is a good way to try and limit exposures, regardless of the antibody content. But when you start looking at the antibody content, there is a lot of RSV IgG as well as IgA in the breast milk. We know that breast milk antibody does not get absorbed or taken up into the neonatal circulation. So in other words, if there's lots of antibody in the breast milk, you can't measure it generally in the baby's blood. But it is in the baby's mucosa, and is particularly in the membranes, the nasal mucous membranes. So my and other people's thought is that breastfeeding can provide some local, temporary, transient immunity, and maybe does help at the nasal and oral mucosal level in terms of ameliorating or potentially decreasing some of the infection. It's very difficult to study how much benefit breast milk has because breast milk is so good for babies. We never would want anyone not to use breastfeeding. The antibody definitely is helpful, but it's not going to get into the circulation, I believe. So it's difficult to exactly pinpoint how beneficial it is in terms of antibody, but it is definitely beneficial to babies.
Thank you so much. I would also like to thank Ziad and Leo for a wonderful hour. I would like everybody to stay on the call to fill out the form, the evaluation form. Thank you all. Have a great day. I hope to see you at our next event. Bye-bye. Please fill out the form.